The use of reflective trigger discussion videos is also central to supporting interactive group learning with LEAP. They help navigate the complexity of palliative care service delivery using dramatic practice scenarios. They enable reflection and dialogue through a set of research-informed stock questions and pause for discussion slides, and the ill-structured design is focused on issue discussion rather than attempts to model a behavior seen in the scenarios.
It's not fair. Is that how you're feeling? And that's okay for us to engage in that. That's not stepping over that invisible line where we cease being helpful. Okay. You're absolutely right. Anything else that you might do? Everybody here would do better, I know that.
Shake hands, just touch.
Shake hands. That's right. Maybe even hold his hand if you know him well enough and you have permission. Know him well enough and have permission. Okay. Anything else that you would do?
Some of the medical terms he was using symbol forms to use.
Medical terms, I know. We talk in that all the time, don't we? Yeah, we could talk, we could have a conversation, you and I, using letters of the alphabet without using a word. PRN, ASAP. Anything else? Anything else you think that we could do? So I think what we could do is we could sit down, talk to the patient, eye to eye, ask them how they are, feel out where they are, and ask them, what do you know? What do you know about your illness? You know, and as we were saying earlier, sometimes people, when you ask that, they'll start at the beginning of their first symptoms. But sometimes they have to do that and take you to where they are now. And sometimes the patient who's, quote, in denial, having done that, will bring you to the place they are now at and say, well, I guess it's not going to get better, is it? And what do you answer to that? So things aren't going as well as we'd hoped they'd go. And it's not a problem for you to say how you feel. I remember one nurse in tears when we were doing one of these talks on communicating and talking to patients, because her head nurse once had caught her crying with a young patient with leukemia who was dying. She said, you don't do that, you're a nurse. You know? And there's no harm saying, I'm sorry that I can't take this away from you. Because studies have shown that patients only want us to be there with them and to not abandon them. They know we can't take this away. So a very different approach. Anything else to add to that? So I think you're much nicer than that guy. Pardon? I think the guy knew him, but that's very important because you don't just walk in and start talking. It's very important that you introduce yourself because the space around the patient is their space. You know, and it's very important that we validate that.
He was a proverbial bull in that China shop.
And the other, he was a bull in the China shop. And the other thing is that I feel sorry for the patient, but I feel very sorry for that doctor. Because, and that's sometimes that we have to recognize that. Yeah. You know, these nasty bad surgeons and nasty bad cancer doctors who don't tell people, they're not all good at it. And they don't know what to say. You know, like Buckman's book, I don't know what to say. And sometimes they're not. And sometimes the pastoral care people don't do it because just because you're good at weddings and funerals doesn't mean you're good at talking to people. Right? So you gotta acknowledge that. Yeah, it's true. Except that they've done the CAPE course, then they're good, aren't they?
Yeah.
And then I was just saying, it's often recommended that we find out from the patient what is their understanding. So the question, tell me, what is your understanding of your illness is a good one. And then it's often suggested that we need to find out from the patient how much information they want and how they want it. And I think it's important, but I sometimes wonder, you go in there and you say, are you someone who likes information, all of it up front, or a little bit here and there? I'm sure it would create some distress and maybe even some suspicion.
Yes.
Could you comment on that?
Well, I see that, and I saw that very early on. And there's something I call a cut-off bid, and that's when you say, now, how are you feeling about how things are going? I'm constipated, I haven't had a bowel movement for 3 days. Now, what does that mean? They don't want to go there, and that's exactly right. There are some people who don't want to go there. Maybe not at this time, maybe not ever. And you know, if we're itching to do all the things we've been trained and taught to do, it's hard to hold back and realize that maybe they don't want to talk about it. And we must be prepared also for the flack that causes in the family and in other areas, because there may be members of the family who really want to say something to the mother or father. If they want to acknowledge the fact that this is a terminal illness and they're dying from it, they can't do that. And we have to help them with that. You know, and for the patient also, I remember there was a patient, Emily, who had bowel cancer, and she had surgery, and she didn't have a bag, and she thought this was the greatest thing, no bag. Didn't want to hear anything about the surgery. She was in her 70s, but of course it was bowel cancer and it was metastatic, and that's why it was an open and close, and she was staying with her sister looking after her. And her sister Anna was looking after her, and she was getting frailer and weaker and more cachectic, and she's saying, Anna, what's wrong with me? I don't know why I'm getting like this. And this poor woman, in her head was this, she told me not to tell her, can't talk about it. So that was a terrible burden on the caregiver.
Yeah.
It's interesting, isn't it? But she didn't want to do it. So what we do is support the caregiver too in that situation. How are you doing? How are things working out? What about that bit where he said, I think I'll get better and I'm going to beat this? What do you say when somebody says that? When you know it's a miracle, which may happen, and it's unlikely. What? Do you have anything you say?
Find out more about how she understands the condition.
What do you mean by that?
Well, you want to know that they are just having false hope, that they didn't understand what's going on, or they knew they just have to put it aside and just at the time.
Right. Are hope and facing reality mutually exclusive? You have to go one way or the other way? No. No, you don't. And you can hope for the best and prepare for the worst. And people, sometimes you have to tell them that. And you know, it may have been appropriate. I don't know this patient, but if I knew this patient, I probably said, you know, I think that will cure me. I would want him to know that I would look after him whether that happened or not. I don't want to burst his bubble, but if we're appropriate, I might say, well, you know, that's what I hope. But if things don't go that way, I just want you to know that we will be here to help you through that as well, whichever happens. Because part of the fear is again that abandonment. You know, if they can't fix me, what's going to happen then? And he may not have heard about you group people in the palliative care team in Richmond. Anything else that you liked about that? You could still have sat down.
That's right.
And sometimes you have to kneel at the bed or just go down like this.
More
that's,
relaxed, yeah. He's a little bit more relaxed, the facial expression.
Yeah.
He seems like very serious or like...
yeah, that's right.
And I like it at the end then that he just had his shoulder.
That was very nice, wasn't it? Yeah.
He did that as initially too. He came.
He did. He touched on. I think he was his family doctor and he felt he could do that, so that was good. And you know, the other thing that sometimes we're afraid to do is validate the patient's feelings. You know, when they say, gee, this is awful, this happened to me. There's no harm in saying you're right. It is. It's not fair. Is that how you're feeling? And that's okay for us to engage in that. That's not stepping over that invisible line where we cease being helpful. Okay.
This scenario illustrates that a family physician, nurse, or other member of the care team is often involved with the patient after they have had information from other providers.
She didn't seem to be listening to him. She was just concerned with the blood pressure and
Exactly.
what he was saying.
Hiding behind A, the white coat, and B, I'm surprised he didn't tell him what his pulse and blood pressure were. Oh, I want George. And I must say, when George started talking, he's just the type of guy that you like, isn't he?
Yeah.
You know, he drinks beer, eats peanuts, wouldn't go on any journey to the end of life, he'll just deal with it. Anything else about that?
He gave her clues to how he was feeling and she totally ignored him.
Yeah,
He said he was short of breath and she didn't go there.
that's right. That's right. Can you imagine what it would feel like to be him or the wife and walk out of there? You know?
She didn't address the wife either.
Oh, that's right. She's doing a great job though. What the job is, I don't know. Maybe he gets flashed from a demon in the middle of the night, she gives him a license. But anything else? That was a very good one though. That was very subtle. I don't know who did this today, but it was really good. So what would you do better? What would you do?
I'll explore this, so it's shorten the breath a little bit, ask him some more questions about that when he gets it.
Yeah.
One last.
Exactly. So you want to find some of the medical aspects we're even missing. You know, does it happen when you lie down? What's that? Does it frighten you? What does it mean to you? Because things mean things to us. They mean sometimes different things to patients, you know. And sometimes when they're telling you something, you know, oh, I have a pain here, doctor. What's that mean to you? Is a question, as well as how often, what type of pain, what helps, what makes it worse. What does it mean? So the meaning of that shortness of breath. And to him it probably means his heart isn't working very well. So yeah, that's right. Anything else that the doctor could have done?
I don't know if there'd be enough.
Pardon?
Update a bit with the medication.
Yeah. Look at the medication and whatnot. Also, he said he thought he was never going to get out of hospital. Wow, was that ever something asking for a segue? You know? What about that? What did you mean by that? And probably he'd go on to say, I thought I was going to die, or I thought I was going to be in the transplant list, or something like that. You know, there was something going to happen from that. Anything else that...
Actually, she could have spoken, asked his wife how she was doing.
Very good point.
You know, it's like she's having to live with him declining.
Yeah. And heart failure is very difficult to deal with because, you know, the patient will do well and then they'll regress and then they'll do well again. And so it's a roller coaster, an emotional roller coaster for both the patient and obviously the wife. So that's something that has to be addressed as well. Yes, Julie? Anything else?
I think if this was his first visit after the hospitalization, she might have scheduled a little bit of extra time and actually talked about what may happen in the future and talk about end-of-life issues.
Right. Yeah. And that was a beautiful time to do it when he said about the hospital, so he'd never get out, and on you go into the end-of-life issues. Yeah.